27.9%.
Wow. Okay, so it is elevated compared to the 15.7% national average. You definitely see the urban effect.
Right, you see the bottom.
But our Baltimore ED study came in at 54.4%. The rate in the specific emergency department is almost exactly double the rate found in the general population of the largest city in the country.
It really is. The disparity is so profound that the authors note this JHHED sample has the highest seroprevalence of HSV2 ever reported from a single unselected population screening site in the United States.
Ever reported.
Ever.
When you hear a statistic that extreme, like the highest ever reported, double New York City, triple the national average, the immediate skeptical response has to be about the machinery.
Oh, of course, you have to question the test.
Right. Could the test just be wrong? If I'm running laboratory and my machine is suddenly throwing out positive results for more than half the samples, my first thought is that the equipment is miscalibrated.
Naturally.
Is it possible the test they used was overly sensitive and just throwing out a massive wave of false positives?
That level of skepticism is mandatory when dealing with outliers like this, and the researchers addressed the mechanics of the laboratory testing extensively.
What kind of test was it?
They used a highly specific diagnostic tool called the Focus Herpes Select 2 enzyme-linked immunosorbent assay, which is commonly referred to as an ELISA.
Okay, an ELISA. How does an ELISA test actually work? Like, how does a machine look at a drop of clear serum and know there's a virus hiding in the patient's spine?
It's actually a brilliant piece of biological engineering.
Okay, walk me through it.
So the researchers take a plastic plate containing dozens of tiny wells.
Little divots in the plastic.
Right. And the bottom of each well is coated with specific proteins or antigens that are entirely unique to the HSV2 virus.
So the viral signature is stuck to the bottom.
Exactly. They then take the remnant serum from the ED patient and drop it into the well.
Okay.
If the patient has ever been infected with HSV2, their immune system will have created specific antibodies designed to hunt down that virus.
The body's defense system.
Right. When the serum hits the well, those patient antibodies will act like a lock and key, permanently binding to the viral protein stuck to the bottom of the plate.
So they physically attach to the plastic.
Yes, exactly. They lock on. The researchers then wash the plate.
Wash it with what?
Just a specialized buffer solution. All the normal blood proteins and irrelevant antibodies get washed away. The only things left stuck to the plastic are the specific HSV2 antibodies from the patient.
Because they're locked onto the viral proteins?
Exactly. Finally, they add a special enzyme that reacts with those locked-in antibodies, creating a colorimetric change.
A colorimetric change? You mean it changes color?
The liquid in the well literally changes color. A machine reads the intensity of that color to confirm the presence of the antibody.
That is so cool.
It is. And multiple peer-reviewed studies have demonstrated that this specific focus Herpes Select ELISA has incredible accuracy, generally boasting a 96 to 100% sensitivity and a 97 to 100% specificity.
Meaning it rarely misses a positive and it rarely flags a false positive.
Under ideal conditions, yes.
Oh, I hear a but coming.
Well, what's fascinating here is the researchers bring up a vital caveat regarding this specific geographical area.
Okay, what's the caveat?
They cite another study involving men attending sexually transmitted disease clinics right there in Baltimore, using the exact same ELISA test.
Same test, same city.
Yep. And in that localized Baltimore study, the sensitivity of the test dropped to 82.6%.
Let's translate what a drop in sensitivity means practically. Because sensitivity is a test's ability to correctly identify someone who truly has the disease, right?
Correct.
So if the sensitivity drops to 82.6%, that means the test is missing almost 18 out of every 100 positive cases. It's throwing false negatives. The antibody is there, but the color change isn't triggering strongly enough for the machine to catch it.
Exactly. And the implications of that are terrifying.
Why?
Well, think about it. If this highly accurate assay is historically known to underperform and throw false negatives in this specific Baltimore demographic, then our mind-blowing 54.4% prevalence rate isn't an exaggeration.
Wait.
It is likely an underestimate.
Oh my God, you're right. The true biological reality of that waiting room could be pushing 60% or higher.
Exactly. It's likely higher than what the data even shows.
But what about the other side of the coin? Like, could the test be throwing false positives, inflating the number that way?
It's a valid question. But to rule out a systemic false positive issue, the researchers looked closely at the data for the youngest patients in the sample.
Why the youngest?
Because if the ELISA test was just fundamentally broken and randomly flagging clean blood as positive, You would expect to see high positive rates uniformly across all age groups.
Right, a broken machine wouldn't discriminate by age.
Exactly. But among the youngest non-Hispanic Black patients, those under 20 years old, the prevalence was much lower. It was 21% for the young women and just 5% for the young men.
Ah. So the machine isn't just printing positive results for everyone.
Right.
The low numbers in the teenagers essentially prove the assay is functioning correctly.
Yes.
So the 54.4% average is real.
It is a mathematically sound reflection of an entrenched epidemiological reality.
Wow.
But an overall average of 54.4%, as massive as it is, kind of obscures the nuance of the epidemic.
Because an average flattens the peaks and valleys.
Exactly. To really understand how the virus moves through the city, the researchers had to pull apart the demographics, the geography, and the socioeconomics to figure out exactly who was driving that massive number.
And to do this, they relied on a statistical tool called an adjusted prevalence risk ratio, or ADJPRR.
Yes, add JPRR.
Let's spend a moment on how this tool actually functions, because the insights it generates are incredible. How do you isolate one specific risk factor when a patient has a dozen different demographic traits overlapping all at once?
Right, it's tricky. You have to use a multivariate regression model.
Break that down for us.
Okay, let's say you look at the raw data and notice that unmarried people have a much higher rate of HSV2 than married people.
Sure.
Your initial thought might be that the act of being single is the primary driver of the infection. But you have to ask yourself, are single people in this sample simply younger on average than the married people?
Right, age could be the real factor.
Or perhaps a higher percentage of the single people happen to be unemployed? A multivariate regression model takes all these intertwined variables, age, gender, race, marital status, employment, zip code, and mathematically holds all of them constant except the one you want to look at.
It's kind of like trying to figure out which specific ingredient is making a cake taste too sweet.
Oh, I like that.
Yeah, you can't just bake a completely different cake. You have to bake the exact same cake, holding the flour, the butter, and the eggs constant, and only change the amount of sugar.
Exactly.
The adjusted prevalence risk ratio levels the demographic playing field so we can see the pure isolated risk associated with just one trait.
That's exactly how it works. And when they ran the 3,408 patients through this multivariate model, the true risk factors emerged with stark clarity.
What did they find?
Well, being female was associated with a significantly higher burden, showing an adjusted prevalence risk ratio of 1.47 compared to males.
Okay, meaning that if you take a man and a woman who are the exact same age, same race, same employment status, living in the exact same zip code, the woman is still 37% more likely to carry the virus.
Yes, precisely.
Wow.
Marital status also maintained its significance after the adjustment. Being single had an ADJPRR of 1.15, and being divorced or widowed carried a 1.28 ratio.
You know, that tracks logically. Well, a divorced individual has likely re-entered the dating pool, increasing their number of lifetime sexual partners, and thereby expanding their window of exposure risk, compared to someone who just remained in a single monogamous marriage for decades.
Exactly. The window of exposure widens. Employment status was another significant factor, with unemployed patients carrying a 1.13 ratio compared to those with jobs.
Okay.
But the most profound demographic factor, the variable that completely dwarfed the others in the regression model, was race.
Really?
Yes. Non-Hispanic Black patients had an adjusted prevalence risk ratio of 2.03 compared to non-Hispanic white patients,
2.03.
over double the risk.
So even when you hold age, gender, employment, and marital status perfectly constant, a non-Hispanic Black patient in this emergency department is more than twice as likely to be seropositive for this lifelong virus than a white patient.
A massive disparity.
We are going to dive incredibly deeply into the intersection of race and gender in a moment, because it forms the most vital and frankly devastating finding of the entire paper.
It really goes.
But first, let's look at the geographic data, because the statistical manipulation of the geography reveals a fascinating illusion.
This part is so interesting. The researchers actually mapped the seropositive blood samples back to the home zip codes of the patients in Baltimore City.
Literally putting dots on a map.
Right. And when you look at the raw, unadjusted data plotted on a map, it looks like the virus is heavily territorial. There were massive geographic disparities.
Like what kind of numbers?
Well, in zip code 21217, An unbelievable 73.9% of the patients from that area tested positive.
Almost 74%.
But if you look at zip code 21224, the rate was 45.3%.
That is nearly a 30-point swing in prevalence just by driving a few miles across the city.
It's huge.
You look at a map with 21217 glowing dark red at 74%, and your human brain naturally looks for an environmental cause.
Right. You want to blame the location.
You start wondering what is happening on those specific streets. Is there a localized outbreak? Is the public health messaging failing in that particular district?
But here is where the brilliance of the multivariate regression model comes into play.
What happens when they adjust it?
When the researchers took that massive geographic disparity and ran it through the adjustment model, specifically controlling for age and gender, a vital statistical twist occurred.
The map changed.
The geographic effect was completely attenuated.
Attenuated meaning the 30-point swing vanished.
Completely. The map just flattened out.
Wow.
The mathematical difference between zip code 21217 and 21224 wasn't being driven by the physical geography at all.
Then what was driving it?
It was being driven entirely by the demographic composition of the people living inside those arbitrary borders.
Oh, I see.
If zip code 21217 happens to have a high concentration of older unmarried women, and zip code 21224 has a high concentration of younger married men, the raw data creates an illusion that geography matters.
It's a statistical mirage.
Exactly. But the math proves that the virus doesn't care about the zip code. The virus only cares about the demographic vulnerabilities of the host.
It fundamentally changes how you view a city.
It really does.
Because it's not something in the water of a specific neighborhood. It is about who is systematically pushed into that neighborhood due to historical redlining, housing segregation, and economic disparity.
Exactly. The virus isn't geographic. The virus follows the demographic vulnerabilities, and the demographics in American cities are intensely geographically segregated.
Right. It proves you can't just aim a public health campaign at a zip code. You have to aim it at the vulnerable populations regardless of where they sleep at night.
It's so true. And while we are dissecting the socioeconomic factors, there was one specific data point regarding vulnerability that stood out precisely because it had absolutely no impact on the infection rate.
Oh, yes. The data on health insurance completely shattered my assumptions.
Think here.
The researchers categorized every patient based on their insurance status: privately insured, uninsured, or covered by Medicare and Medicaid.
Right.
Logically, you would assume that lacking health insurance means you cannot afford preventative screening, which means you don't catch STIs early.
Which should lead to rampant unmitigated transmission in the uninsured community.
Exactly. You would expect the uninsured bar on the graph to be towering over the insured bar, but they found absolutely zero statistical association.
None at all. The rates were practically identical across all three groups.
What were the numbers?
The uninsured prevalence was 54.9%. The insured prevalence was 53.7%. And the Medicare or Medicaid prevalence was 55.5%.
Statistically, it is a completely flat line.
Insurance status offered zero predictive value.
Why does a piece of plastic in your wallet that guarantees access to medicine completely fail to protect you from this virus?
It all comes back to the stealthy biology of HSV2. Because the virus is subclinical in almost 90% of cases, the presence of health insurance is actually irrelevant to the initial detection.
Because you don't feel sick.
Exactly.
Oh.
A person with top-tier private insurance who feels perfectly healthy is not going to schedule a doctor's appointment to ask for an invasive blood draw to check for an STI they have no symptoms of.
Right. Insurance only helps you if you know you need to use it.
Precisely. Both the insured executive and the uninsured laborer are equally blind to the subclinical shedding happening on their skin.
The 87.4% unawareness rate perfectly spans the economic divide.
It really does. But it also speaks volumes about the specific nature of the Johns Hopkins ED patient population.
Right, because we have to remember the context of the geological core sample we talked about earlier.
Yes. This ED primarily serves an inner-city population where structural barriers to healthcare go far beyond just possessing an insurance card.
Meaning even if you have coverage, you can't necessarily use it.
Exactly. Even if a patient in this community qualifies for Medicaid, they might not have reliable transportation to a clinic. Or they might not be able to get time off work during normal clinic hours.
Or there simply might not be enough primary care physicians taking Medicaid in their zip code.
Exactly. Their access to routine, preventative, relationship-based medicine is universally low across the board.
So for this specific population, the insurance card is a hollow metric.
It is. The actual drivers of the epidemic are age, gender, and race.
Here's where it gets really interesting. And frankly, this brings us to the most critical, devastating section of the entire study.
It's a tough look at the data,
Yeah.
but so necessary.
When you combine those three real